Good morning to all. Today we will discuss on acute renal failure. So let us first know what is acute renal failure. It is a syndrome which is characterized by rapid onset of renal dysfunction. Okay, there will be suddenly the onset of renal dysfunction will be the sign and symptoms will occur suddenly. Okay, acute, and chiefly oliguria and anuria. Oliguria means very low urine output. Okay, by oliguria we can say that urine output is which is below 400 ml in 24 hours. Okay, when you see the urine output of a patient in the last 24 hours, if it is more than if it is less than 400, then it is known as oliguria. Then anuria means very less urine output or no urine output. Okay, the person will not be having any urine output. This indicates less than 100 ml in the last 24 hours. So if the patient is having no urine output or the urine output is 60 or 70 or 50 like that, then it is known as anuria. Then there will be sudden increase in metabolic waste products like urea and creatinine and in the blood resulting in azotemia. Okay, there will be increased amount of urea and creatinine in the blood. When you do the kidney function test, then the amount of urea and creatinine in the serum or the blood, it will be increased, and the nitrogenous waste will also be increased. That is azotemia. Then next is the etiology. In the etiology, there are three main types. Okay, due to the pre-renal causes, intrarenal causes, and post-renal causes. In the pre-renal causes, what will happen? It accounts for 55 to 60% of acute renal failure, and it is caused by the inadequate cardiac output and hypovolemia or vascular disease causing reduced perfusion of the kidneys. So here in this, what will happen? In the pre-renal causes, the factors those decrease the effective blood flow to the kidney. This is because of the factors which decrease the effective blood flow to the kidney. If there is not enough blood flow to the kidney, then it is known as pre-renal, and it will cause the decrease in glomerular filtration rate. Okay, if there is no effective blood flow to the kidney, then it will automatically cause the glomerular filtration rate, decrease in the glomerular filtration rate. Okay, then the factors which cause the ineffective blood flow, they include the low blood volume, low blood pressure, heart failure, okay, then liver cirrhosis, like this. Okay, so these are the factors which causes the pre-renal causes. Then next is the intrarenal. Intrarenal means within the kidney. It refers to disease process which directly damage the kidney itself. Okay, it can be due to one or more of the kidney structures, including the glomeruli, kidney tubule, or interstitium. Okay, then in the post-renal, what will happen in this? It refers to the acute kidney failure. Okay, which is caused by disease that decreases the downstream of the kidney and also occurs as a consequence of the urinary tract obstruction. Okay, that means it causes due to the obstruction of the urine flow from the kidney to the ureters or the urethra. Okay, then in pre-renal causes 50 to 60%, intrarenal causes 35 to 40%, then post-renal causes less than 5%. So the most common cause is 50 pre-renal cause. Then next is the pathophysiology. In the pathophysiology, first there will be increase in the intraglomerular pressure with the glomerular hypertrophy as the kidney attempts to adapt the nephron loss to maintain the constant glomerular filtration. Okay, in the causes or the etiology, it is known that there will be decrease in the glomerular filtration rate. If there is decreased glomerular filtration rate, then the kidney will try to filtrate more. Okay, due to this, the nephrons are already damaged, but the kidney will try to filtrate more. The kidney will try to filtrate the normal amount. Because of this, there will be pressure inside the glomerulus. Okay, then due to the pressure, what will happen? There will be failure of the renal circulation and glomerular or tubular dysfunction. There will be dysfunction in the glomerulus or the tubular, that means the tubules, okay, and failure of the renal circulation, that means exchange of fluids and electrolyte balance, okay. Then this will damage the tube. This in what will happen after this? This will, the damaged tubules cannot conserve the sodium, okay. The sodium which is to be conserved by the kidney, it cannot be conserved, okay. Then it will normally activate the renin angiotensin aldosterone system. So the renin angiotensin, then due to the activation of the renin angiotensin aldosterone system, the sodium and fluid retention will be there, which will lead to edema. RAAS will cause the sodium and water retention inside the body. Then if there is sodium and water retention inside the body, then it will cause edema, okay, buildup of fluid. Then it will cause a sudden and complete loss of kidney functions, then reduce blood flow to the kidney. Then lastly, this will again cause what? Increase serum creatinine, B1 level, okay, all the creatinine, urea level will be decreased, metabolic waste will be increased inside the blood. Then increase circulatory overload, okay. If there is fluid, that means fluid overload will be there in the body. Increased amount of fluid will be there, it will not be able to come out of the body through the urine. Then sodium retention also will be there. Then what will happen? The person will be having hypertension and all. Then and lastly, it will cause the acute. The next is the clinical manifestation. Clinical manifestation depends on the cause of the acute renal failure and the stage of which disease patient presents, okay. It includes one of the three major patterns, that is syndrome of acute nephritis, syndrome of accompanying tubular pathology, then prerenal syndrome. One of these three or all of these three patterns will be present in the patient. The first one is syndrome of acute nephritis. Under this, there will be increase in glomerular permeability, decrease in glomerular filtration rate. So the characteristic features are proteinuria, that is protein in the blood, hematuria, proteinuria means protein in the urine, hematuria means blood in the urine, then edema will be there, okay. Then next is a syndrome of accompanying tubular pathology. Under these three phases are there: oliguric phase, diuretic phase, and recovery phase. Under the oliguric phase, it will last for 7 to 10 days, okay, with less urine output, that is less than 400 ml per day, which is also known as oliguria, okay. Then it will lead to the accumulation of waste products of protein metabolism in the blood, okay. Then will lead to azotemia, metabolic acidosis, okay. Hyperkalemia, metabolic acidosis means high amount of acid inside the body. Hyperkalemia means high amount of calcium. Then hypernatremia means high amount of sodium. Then hypovolemia, fluid overload will be. The next is the diuretic phase. Here the healing of the tubules will result in the improving urinary output. This is because of drawing water and sodium by high levels of creatinine and urea in the tubules. Then there will be dehydration and electrolyte imbalance, okay. So here there will be improved urinary output. Urinary output will be there, little amount of urinary output will be there, and due to this there will be dehydration and electrolyte imbalance. Then last is a recovery phase. In this, there will be full recovery of the tubular cells, okay, in half cases, while others terminate in death. Others result in death, while in the half cases there will be full recovery. Then this recovery doesn't take 1 or 3 months, okay, it takes up to 1 year for the full recovery. We had three syndrome, okay, three characteristic syndromes. First one is a syndrome of acute nephritis. Second is a syndrome accompanying the tubular pathology. Under that, there will be oliguric phase, diuretic phase, and recovery phase. And third one will be prerenal syndrome. This prerenal syndrome, it occurs because of secondary disorders like decreased blood flow to the tissues and not due to the glomerular or tubular damage. So some of the symptoms include electrolyte imbalance, hematuria, oliguria, dehydration, then pale skin or poor appetite. Then another diagnosis, we can do the routine blood test, then ultrasound of kidney, then kidney biopsy. Okay, when all of us know this one. Then under the medical management, we can give the antihypertensives, antihypertensives to decrease the blood pressure. Then in diuretics to increase the urine output. Then under the nursing management, we can measure and record intake and output. Okay, intake and output should be strictly measured by the concerned staff nurse. Okay, if there is any wound drainage, okay, if the person is having after surgery, if the person is having any wound drainage, that should also be counted as the output. Then nasogastric output, from if the patient is receiving the nasogastric feed, then if we are doing this one, extracting the gastric contents, then that amount should also be added. Then diarrhea, if the person is having diarrhea, okay, then that amount should also be included in the output. Okay, we cannot say that the person is not having any output as there is no as there is no urinary output. If the patient is having diarrhea, wound drainage or nasogastric output, then it will also be counted. Okay, if the person is having 100 ml nasogastric output, then it will be counted as output 100 ml. Okay, then next is the weight of the patient daily. Why? Because there will be fluid retention inside the body, right? If there is fluid retention, the weight of the patient will decrease. And after medication or after the treatment, if the person has improved, okay, like if he is having no more edema inside the body, no more fluid retention inside his body, then the weight will be come to its normal weight. Okay, then next is if we should measure the blood pressure. Okay, due to the activation of the RAAS, okay, there will be increase in the blood pressure. So we should, and the patient will also be receiving the hypertensive drugs. So we should always check the blood pressure with this. We should see if it is increased or decreased. Then maintain the nutritional status, which would provide a high calorie diet, low sodium and low potassium diet. Why low sodium? Because the person will be having this sodium retention inside the body. There will be high amount of sodium inside his body due to the failure in the excretion of the sodium. So if we are giving a diet which is more of sodium, then there will be more accumulation of sodium inside the body. Then provide small and frequent meals to anorexic patients. Then monitor the blood urea, nitrogen, creatinine, electrolytes, okay, like sodium, potassium, calcium, magnesium, chlorine. This all should be monitored. Then urea, creatinine should be monitored. Then follow strict aseptic technique while caring for the patient. Okay, these patients are highly susceptible to infection, so we should provide the aseptic techniques. We should wear gloves while handling the patients and all. Then institute seizure precautions, provide padded side rails and have airway and suction equipment at the bedside. This is for the patient which are dependent. Okay, and if the patient are highly dependent, then we can provide the side rails so that the patient does not fall, so that the patient does not get any injury because of seizure. Then if the patient has seizure, then I throw off also. So we should always get the suction ready, and so that the airway will be provided. Then provide good mouth care, okay, because membranes will be dry, so we should provide a good mouth care. Then encourage and assist the patient to run and move, because drowsiness and lethargy may reduce the activity. This means that we should let the patient do some exercise, do some light exercises. If the patient requires hemodialysis, check the blood exercise every 2 hours for patency and signs of clotting. Okay, this is for hemodialysis patient. The hemodialysis and dialysis we will discuss after this. Okay, in the next classes we will discuss dialysis. Then we should check the site in which the patient is having the dialysis. Okay, then wait the patient before dialysis. Before the dialysis also we should wait the patient. During the dialysis we should monitor the vital signs, clotting time, blood flow, okay, arterial blood venous pressure. All this should be monitored. During dialysis we should check and we should observe the patient closely. We should not let the patient alone during the dialysis. Okay, we should observe for any changes in the vital signs, blood flow, etc.